attributes, we already talked about the importance of, not breaking up the IgG in any way, so it mimics what's in the serum, and also that it matches in terms of subclasses what you get in serum. So roughly 60% IgG1, 30% IgG2, 6% IgG3, and 3% IgG4, and the extra percent comes from somewhere. So it kind of matches that natural constitution. Again, most contain trace IgA. There are a couple, as I'll show you, which contain hardly any, and those certainly would be a good choice for truly IgA deficient patients. Again, the current approach is pooled plasma from more than 1,000, more like 3,000 to 10,000 donors, and I've sort of laid out the trade-offs. The more donors you have, you're more likely to get, a broader spectrum of what's in the IgG, I suppose. But then you also potentially dilute extremely rare, potentially useful activity. The sort of standard cone procedure that COHN developed about 60-some years ago is using this cold alcohol fractionation. You remove the immunoglobulin fraction, precipitate it, etc. And there are a number of pathways to inactivate pathogens as best we know. Again, trying to minimize IgA. And the WHO criteria, as you can see, are mimic that. So this is a reasonably up-to-date table that I put together until 3 days ago. There was a new product delivered. Yeah, if you go through the table, you'll see some, even though the names are different over here on the left, you can kind of get a glimmer that, for example, Caramune and Sandoglobulin are essentially like Swiss Red Cross products, and they have very similar attributes. I honestly don't know why they're two different products, but you can see the formulations vary in terms of percent IVIG in the product. Some of them are lyophilized, which is the LP. Some of them come ready to go. That's important. The solution. And you can see most of them are prepared by this cold ethanol fractionation. I've highlighted a couple in yellow, things that may or may not be important. I guess for keeping the sodium concentration low, if that's important. Or again, there are two products that have very little IgA, and then the pH is somewhat variable.
Well, the pH, having like a pH of 4.5, that is quite significant.
It is.
Expect like significant acidosis after.
Yeah, exactly. Yeah, and you can see that's similar to the both the Gamma-Munin and the Gamunex are clearly kind of created in a similar fashion. And I honestly don't know the story about why that product is so acidic. And the other thing keeping in mind is it's a fair osmotic load, so you don't want to give this extremely quickly, like let's get done with the infusion, or you can create a hypertensive patient pretty quickly. Again, and this is of course a theme that we all deal with biologics now, it's just common sense to let this warm up to room temperature before you give it. I have, I think, 4 patients that actually get infused at home. Nurse comes to the home and does it once a month. This is CVID patients, not what we're talking about here. Typical replacement doses for immunodeficiency are 400 to 800 milligrams per kilogram per month, as we'll see in the context of what we're talking about today. Typical doses are much higher. Some of the initial protocols, not quite sure what they were doing, I suppose, gave like 0.4 per kilo for 5 days in a row. But then gradually the protocols got to giving more and more all at once. Because the idea is you want the beneficial effect as soon as possible. Pharmacokinetics are what you'd expect given the half-life of IgG, so it's about 3 weeks. And then just mentioning a number of things that are important as far as screening and following patients. So very briefly, in terms of primary immunodeficiency, and we won't get into this, but obviously these are sort of the indications for patients that have a primary problem, patients that functionally either have no IgG or poor B cell function at many different levels. The transient hypogammaglobulinemia of infancy, the fourth point, is controversial. I suppose it depends clinically how much problem the child has had. Obviously, by definition, there's a reason you would pick it up, right? In other words, if that child's having a lot of infections, you check their IgG. But if you evaluate them otherwise, and there may be other ways you can support them, most children with this have a grow this by definition. The normal IgG, normal antibody responses, I think, remains controversial. I suppose if the patient is truly having a specific subset, especially the largest one, IgG1, you could make an argument for attempting a boost if other measures don't work. And then a variety of other conditions like Wiskott-Aldrich, ataxia, telangiectasia, et cetera, that are functionally have humoral immunodeficiency. All right, let's shift here to each of those sections I mentioned earlier. We'll talk about secondary immunodeficiency. And here I've just tried to summarize, from the literature, what's the bottom line. For CLL, really the approach here is using IVIG if the patient is demonstrably immunodeficient. So you would work them up like any other patient where you're concerned about that. For multiple myeloma, prevention of infections, including sepsis, but for both of those two, the researchers note that it may not affect the ultimate clinical outcome in these patients. As I alluded to earlier, if we go back, several years ago, and this is still an approved indication for pediatric HIV, this can be a useful adjunct, but I think largely this has drifted to the background with the development of more highly active antiretroviral treatments. Just briefly, other conditions where you might make a pitch for relative humoral immunodeficiency on the front end, prematurity, on the back end, aging, and we know those patient groups are functionally immunodeficient. But as you can see with prematurity, it really didn't have a marked impact. Again, aging, we know that the polysaccharide response wanes, just like it's a problem early in life. And I would submit now with the data of giving conjugated vaccine followed by regular vaccine in patients that are older than me, I think it's had such a huge impact that this is probably not a strong indication.
You're close, though.
I know. Yeah, well, I actually am 60. I got my throat. All right. And then a variety of other conditions that potentially have humoral defects. Other conditions, cell transplant with hematopoietic cells, again, routinely used over 20 years ago, can be useful for modulating graft versus host disease. Now the gold standard is a different sort of primary approach, but some potential uses still in patients who have demonstrable ongoing humoral defects, etc. Certainly indicated for skin patients, really by definition, because they have humoral defects prior to transplantation and also afterwards until they can demonstrate that they've reconstituted their humoral system. Solid organ transplant. This can be useful in highly sensitized patients to HLA and ABO antigens. The current approach there is using high dose, for example, 2 grams per kilo, as well as rituximab. As far as antibody-mediated rejection, again, antibodies against donor-specific antigens. Again, a couple studies noting high-dose IVIG versus plasma exchange, and that has, I think, progressed now to the favored approach of high-dose IVIG and rituximab. And with that later approach, they have found improvement in graft survival 3 years out, going from 50 to almost 92%. So pretty impressive adjunct. Again, another group of patients that are B-cell depleted. This has a potential role in preventing infection with, if you will, opportunistic viruses like CMV, parvo, and polyomaviruses, including the BK virus and the JC virus. B-cell depletion, by definition, of course, you know this is going to create a humoral problem. And the authors make the point that it's worth obviously measuring if there's a problem before you even start on rituximab. But many patients after B-cell depletion have persistently low IgG and therefore functionally could benefit from a boost. The authors sort of argue about what's enough. Most people think, 600 to 800 milligrams per deciliter is enough as far as replacement. All right, so let's shift gears a little bit and we'll talk about autoimmune disease. Here the sort of poster child, and this is one of the approved indications for IVIG is ITP, but also can be used for other autoimmune cytopenias. Again, it's demonstrably useful in increasing platelet counts and can be used as an adjunct to other immunomodulators, including steroids, rituximab, and plasmapheresis. Other similar scenarios are neonatal alloimmune thrombocytopenia. The authors make the note that even if you give a high dose, though, especially in a premature infant, it may be too little, too late, but it's certainly, of course, worth a try. Rare situations, post-transplant purpura, also another indication. Other autoimmune disorders, PTP, which is fairly rare. I don't know. I've never seen a case. Anyone in this room seen a case? A couple patients. So this is felt to be actually a defect often or a mutation in ADAM TS13. And I put the acronym on the bottom because I knew I wouldn't remember all of it. So basically what this also is the enzyme that cleaves von Willebrand factor. So if you don't have this and you have an activation with infection or an immune insult, you get these multimers of von Willebrand's factor, and that initiates an inflammatory response in essentially a vasculitic situation. Other autoimmune cytopenias, as noted, although these are largely anecdotal reports. Shifting to rheumatic disease, it's felt that this IVIG can be a useful adjunct to steroids and other immunomodulators such as azathioprine and mycophenolate, and has been shown to be steroid sparing in not all, but at least 2/3 of patients. How much steroid sparing? Like a 50% reduction. Some benefit in RA with high-dose IVIG, no benefit with lower doses. Quite frankly, I don't know what the rationale was using such a low dose of 5 milligrams per kilo, but that had absolutely no effect. Years ago, it was considered a first-line attempt of treatment in JIA. Now that has been largely supplanted by IL-6 inhibitors and other biologic approaches, but it can be, again, a useful steroid-sparing agent, just like in the autoimmune inflammatory myopathies. A couple other more rare disorders. Still's disease essentially is JIA with high fevers, more of a systemic onset JIA. Felty syndrome is RA with neutropenia and splenomegaly. The authors make the note, though, in Still's disease that half the patients spontaneously remit. So it's not something you jump right in on at the beginning, but if a patient is critically ill and not responding, this is definitely an approach. With Felty syndrome, again, 2 of the 3 problems remit, but not the neutropenia typically. And why that is not well understood. Other rheumatic diseases, lupus, this can be a consideration. As you can see, that some patients seem to improve if they have organ-specific disease. That's a critical part of their disorder, at least in about 2/3 of patients. But a cautionary note is there's some risk of thromboembolic events in these patients with using IVIG. Other sort of small vessel vasculitis, scleroderma, again, there is improvement noted with multiple doses. A single dose of 2 grams per kilo doesn't seem to modify the disease. HSP, sort of post-infection vasculitic disorder, IVIG has been shown to be useful if there is GI hemorrhage present, but again, most cases are self-limited. So again, depending on the clinical severity. Medium to larger vessel disease like polyarteritis can be a useful adjunct to biologics, etc. And then in the ANCA disorders, these are just purely case reports of benefit in either Wegener's or Shirk-Strauss. Some organ-specific autoimmune disease. Again, case reports of improvement in diabetes decreasing, and this is type 1 diabetes where there's an autoimmune component, but a larger randomized controlled trial really showed that this was not statistically significant, and I think that's been abandoned. Specifically, the ophthalmopathy, I can't say it, ophthalmopathy, the eye disease and Graves' disease, as effective as steroids with less side effects. So it's felt like this is an appropriate thing at this level, 1 gram per kilo for 2 days, and then repeating that for 3 weeks times 6, so about 20-week course. Again, rituximab is emerging as an alternative or adjunctive approach. Very rare disease, autoimmune uveitis, some clinical benefit in about half the patients. Autoimmune liver disease, inflammatory bowel disease. Again, a sort of second choice consideration in refractory patients. And again, I'm not sure why the authors actually chose this section as atopic disease. And ironically, some of these are not purely atopic patients, but bear with me. So a couple of positive small case studies, and these are both out of National Jewish, literally almost 30 years ago. It's very small groups, but did show a steroid-sparing effect of high-dose IVIG. This was over a period of 6 months. The second study with Joe Spahn and Erwin Gelfand, by a very complicated mechanism, felt that IVIG's mechanism was actually enhancing the binding of steroids to the glucocorticoid receptor, which is an interesting mechanism potentially. But then several larger studies, several years later, really showing no benefit versus presumably a placebo and albumin. There was a trend in the Salmon study of a positive effect, but only in patients who had more than 2 grams of prednisone in the prior year. And this was the dosing regimen. And so the bottom line is this could be a consideration, again, if there's an underlying immunodeficiency component, and that's the reason for example, sinus disease worsening the asthma. But again, I think the theme here is with the advent of multiple biologics to target this pathway, there's less and less of a potential role. Urticaria, this is specifically chronic urticaria, as you know, is truly not an atopic disease, but they put it in this category. Again, felt to be potentially effective if there was a demonstrable autoimmune mechanism, although that's contradicted by the small second series. So the first series showed remission in 5 to 6 patients treated with IVIG high dose for really 4 to 6 months. That effect went away the minute you stopped therapy. Smaller reported 3 patients that did have a positive autologous skin test really showed no effect. As far as pressure urticaria, this is, I guess, like flipping a 3-sided coin. It either worked great, it worked half-heartedly, or it didn't work at all. So really nothing earth-shattering there. Solar urticaria, interestingly enough, I believe this was about 7 patients, so a small group, but remission in a high percentage of patients over 6 to 12 months. Again, the bottom line, there was no clear evidence of benefit in a high percentage of patients, and possibly a consideration after traditional immunomodulators are I think, more rising to the forefront now would be omalizumab.
Frank, is that really milligrams per kilogram on solar urticaria? That's a pretty low dose. It'd be like 1 gram.
Yeah, I'm sorry, yes, you're right, it should be grams.
Okay. That'd be easy to treat.
Yeah, that's right. It's in the air.
1 gram.
Atopic dermatitis, again, for severe atopic dermatitis, this is sort of looking at several studies, and as you often get, there's a potpourri of approaches, but everywhere from 300 to 2,000 milligrams per kilogram monthly for 6 to almost 4 years. A high percentage of patients, as you can see, did seem to have a positive response within 3 to 6 months. If you look at the response in terms of SCORAD improvement, though, it is about half of what one gets with dupilumab, just to put it in perspective. So again, another situation where this certainly was a consideration, possibly versus the side effects of immunomodulators years ago, but I think, again, where biologics probably are going to move up the ladder. In adults, though, and it sort of raises the question, did these patients all truly just have simple atopic dermatitis? Very minimal improvement in 2/3 of patients, and the rest really had no improvement. And unclear why the difference versus kids. So shifting to infectious disease, again, sort of the poster child here, or felt to be an infectious disease related. Kawasaki's disease, which causes this medium-sized vessel vasculitis, and probably the most worrisome side effect is coronary aneurysms. These patients have platelet counts of often 1.5 million. And so the standard of care now is 2 grams per kilo of IVIG along with aspirin. And as we'll see, the addition of prednisolone further reduces the risk of coronary disease. The irony of it all, though, is treating with prednisolone without these other factors actually increases the risk of thrombosis and coronary disease. So it's very important if you suspect Kawasaki's versus other things that might mimic this, like those streptococcal things and so forth, that you really do some serology, and if you hear a murmur, etc., really nail down the diagnosis and do everything at the same time. Not, let's see if prednisolone helps, because it actually may harm the patient. And then secondary doses if the patient is not having a marked response early on. As far as HIV, it's not felt to be effective in reducing viral burden, but can be useful again to reduce the risk of secondary infection. As far as sepsis, toxic shock, this can be useful as far as reducing mortality, and this is the mechanisms here are probably being helpful to reduce some of the toxins that initiate cytokine storms, and specifically viral pneumonitis. It is in immunodeficient patients or B-cell depleted patients. This can be a useful adjunct to antivirals. And RSV also can be a useful adjunct, especially in preemies that still get disease despite palivizumab prophylaxis and treatment with ribavirin. Other infectious disease, in terms of gastroenteritis, you can see the potential impact in shortening the course with rotavirus. Other causes, though, really variable effect on the course. Enteroviral meningoencephalitis, this is, and again, these BPK patients would be on IVIG anyway, but if patients get this, or perhaps were unrecognized with the disease, it actually is given intrathecally as well. It may help eliminate this as being a chronic disease, but may not really help the course, unfortunately, short term. Again, parvovirus, possibly useful for clearing the virus. Endocarditis and rheumatic fever, really no benefit in this disease. Switch gears very quickly to neurologic disorders. Guillain-Barré has been shown to shorten the course. Really no difference between plasma exchange, IVIG, or plasma exchange followed by IVIG. So most people feel one of the approaches alone, and IVIG is certainly easier to do, is probably the way to go. A disorder called CIDP, or chronic inflammatory demyelinating polyneuropathy. This does improve disability. Multifocal motor neuropathy also felt to be, and these are not direct indications, but these have high levels of support from randomized clinical trials. And then the final disorder I will get to in the interest of time.
Tell them to mute their phone.
Yeah.
Who's ever out there, you need to mute your phone.
Neuromuscular junction syndromes, myasthenia gravis, where the autoantibodies to the cholinergic post-synaptic receptor. IVIG is felt to be comparable to plasma exchange, but variably effective in chronic disease. Lambert-Eaton myasthenia syndrome, which is an antibody to the presynaptic area. Positive short-term effect, but again, variable effect in chronic disease. In multiple sclerosis, it has been shown to reduce exacerbations and disability short-term, and may even prevent progression of disease. And then intractable childhood epilepsy, and there's of course many forms, but there's this very specific syndrome, which is a genetic defect. This reduces seizures by 50% in half of the patients. More recent data, though, there's a company called GW Pharma in the UK that actually makes a CBD product, which is much more effective than this. It probably eliminates 80% of seizures in 80% of patients. Blistering diseases, improvement in a high percentage of patients. So again, this is certainly a strong consideration in these diseases. High doses, 1 or 2 doses, followed by monthly until controlled, and then less frequent as tolerated. There's some evidence in TPM and Stevens-Johnson that it helps progression of disease and can reduce mortality. But that was just a trend and not statistically significant. And very briefly, some other miscellaneous uses. Cardiac disease. It has been shown to be useful in parvovirus cardiomyopathy. But if you look at more non-specific cardiomyopathy, it had no effect. CF, really no evidence of adding this to standard regimens has been helpful. But again, the patient is hypogammaglobulinemic, so that's another indication. It could be a useful boost. In renal disease, can be useful for IgA nephropathy, as noted. And then in patients who have transplant, can be useful as far as modulating the risk for polyomaviruses and CMV. Again, briefly, acquired autoimmune coagulation factor inhibitors, etc. IVIG alone is effective in 30%, but if you combine this with immunosuppressive therapy, that ramps up to 70%. Immunosuppressive alone is about 50%, so you clearly get a synergistic effect of doing both. Antiphospholipid antibody syndrome, it's been shown to be effective in preventing recurrent spontaneous abortion in these women, but only if they have other autoimmunity, which is a case about 30% of the time. Chronic fatigue syndrome, case reports, of course, but this is, of course, a mixed bag of patients and not effective in double-blind studies. Autism, a couple trials in about 40 patients, no benefit over 6 months. And this rather bizarre pediatric syndrome called PANDAS, as outlined here. Typically, these patients present post-streptococcal disease with things like new onset OCD and tics. And it does seem to be useful in reducing symptoms in some of these patients.
And some of these things, how do people even justify? What's the thought process that this product might help this?
Yeah, I think it's that simple. Like, we don't know what else to throw at this. And, you know, and as you've seen, the theme is now we do have other things to throw at, a lot of these things that are probably much more effective and less risky. But I think that's right.
Right. There's no logic.
No, there is no logic, so then let's try it. So just in brief, just a brief summary, and I've tried to outline in the yellow here, where there's either an approved indication or there's pretty solid level 2 evidence with either meta-analysis or pretty well-controlled studies that you could get this approved. So CLL, multiple myeloma after B-cell depletion, solid organ transplant, and SCID patients. In terms of autoimmunity, ITP, dermatomyositis, severe idiopathic juvenile arthritis, including Still's disease, and then the eye disease in Graves' disease. And then this I actually just snipped out of the review article showing you multiple other specific things, which I didn't even talk about, but you can see the level of evidence. So ITP 1A basically means reviewing a meta-analysis of well-controlled studies. There's very solid evidence. As it progresses to 2, it's often a single well-controlled study or 2 But as you get to 3 and 4, often these are case reports and really not placebo-controlled studies. Again, not truly atopic disease, but in asthma, really lack of evidence, chronic urticaria, lack of evidence. And I would submit for both of those things now, biologics for difficult to control patients are clearly the approach of choice. And actually for probably atopic dermatitis as well. Infectious disease, again, Kawasaki's and pediatric HIV are the 2 approved indications. But again, if a patient is clinically ill and we have no other therapy, it might be a consideration for the virus, etc. Again, I think in pediatric HIV, because of the advent of more effective antiretroviral therapy, this is less used now. And again, a similar table for other infectious diseases where it's been studied. Neurologic disease, CIDP, MMN, Guillain-Barré. The others are a little more controversial, but as I showed you, some evidence of efficacy in progressive patients. And again, a similar table. Miscellaneous uses, we talked about TEN, Stevens-Johnson, other blistering skin diseases. Again, pretty solid evidence. And again, a similar table. All right, so let me stop there. I'm going to show you, because Gary's not here, so I'm obligated to put a few science slides in. So this is kind of an interesting, this is actually kind of from some UW work here. And the stimulus for this was noting increased levels of methane in ocean water. So they went down, this is a sonogram of the ocean floor, and what you're seeing is methane escaping as the subduction plate off the coast slides under the North American plate, and the reason is felt to be global warming. In other words, this is actually frozen methane that's now being released and heated up, and has been raised as a concern affecting, of course, the fish and so forth over time. Not sure what we're going to do about it. This probably all of you have seen if you pay attention to the news recently, and it's a bit of an oxymoron. This is actually sort of a picture of a black hole. So obviously, as you know, probably a black hole is it's sort of collapsing, and as a star collapses, it's a very dense object, and it's so dense that the force of gravity doesn't allow light to get out. So a group of very clever astronomers got together all over the globe, and they kind of used data simultaneously. So they actually had an atomic clock take a picture from large radio telescopes on 8 places around the globe. And what it functionally did is create a telescope the size of the Earth. And you can see the amount of data that's generated. And there's a picture on the internet of this woman pulling out these hard drives, and it's literally a room full of hard drives to reconstruct this picture. And so what the picture is as photons go past the black hole, they take a U-turn because the gravity is so strong. And essentially, you do that in all directions, so you get this rim of light that you need. So keep in mind how far away this is. Okay, so the speed of light's 186,000 miles per second. This is 55 million light years away. So you just don't have enough with even our best telescopes alone to do this. So pretty impressive.
So we've all seen that in the news and
Yeah.
the front page of the Times. Go back just a second. So is the light or photons being sucked into the center black hole?
Yeah, and some of them, don't have enough energy, so they literally are